All right, so I believe it's going to ask you all if you consent to being recorded. So if you click that, and we can get started. All good? Thumbs up if you're ready to go.
Yeah.
All right. Hi, my name is Angelica Adcock, and today we are doing a harm reduction discussion panel. This is being hosted by the McLean County, Livingston, and Ford County ROSCs. Before we get into things, here are the plans for the panel tonight. We're going to do some brief introduction with all the panelists, and then we're going to discuss some different questions that we've gathered. And then towards the end, if anyone has any questions, comments, we will address those. So introductions. First, we have Marita. Would you like to tell us a little about yourself?
Sure. My name is Marita Landreth. I'm a registered nurse. I currently work at the McLean County FUSE program. FUSE stands for Frequent User System Engagement. It's a wraparound case management program for people with serious mental illness. I'm certified in psychiatric and mental health through the State Boards of Nursing, and I do have previous experience working with inpatient chronic illness education and medically monitored detox services.
All right, great. Thanks for sharing, Marita. And next up, we have Kevin.
Hi, my name is Kevin Steidinger. I am an LCSW therapist. I'm currently working as a mental health therapist in Livingston County. And I'm here today just because I am passionate about, helping people who are struggling with substance use issues and trying to find the best solutions for whoever needs it.
All right, awesome. Thanks for sharing. And next we have Kate.
Hi, good evening. I am Dr. Kate Ostman, and I am a board certified family medicine physician as well as addiction medicine. I did family medicine here in Ford County out of Gibson Area Hospital for 15 years, including obstetrics, and then was realizing the need for addiction services in this area. So I went back briefly to school and did some extra training in addiction medicine. And so along with my staff, we treat a variety of substance use disorders, but we also continue doing family medicine as well at Gibson City.
Awesome. Lauren wasn't able to make it, but the next up we have is Micah.
Hi, I am Micah. I am a peer recovery specialist and I work for Dr. Osman in Gibson. I am, like it says, a person with lived experience. I am a recovering heroin and fentanyl addict, and I went the methadone route getting sober. So I am here as a person with lived experience with firsthand knowledge of harm reduction.
Awesome. Thank you all for introducing yourselves. I'll do a brief introduction of myself as well. My name is Angelica Adcock. I also do have my CRSS as well. My recovery is with mental health though, and I am an adult child of an alcoholic. I currently am working with the McLean County ROSC on some things, and I am super grateful to be here to be a moderator for this discussion panel today. So obviously the discussion is about harm reduction. So before we get into it, I wanted to give a brief definition on harm reduction, just in case if there are some people that aren't familiar. This definition was taken from the Harm Reduction Institute. Harm reduction refers to policies, programs, and practices that aim to minimize negative health, social, and legal impacts associated with drug use policies and law. It's grounded in social justice and human rights, so people can focus on positive changes while working with people without judgment, coercion, discrimination, or requiring that they stop using drugs as a precondition for support. So now I open this up to everyone in the discussion, the panelists. What does harm reduction mean to you, and why is it important? Whoever wants to talk first, go ahead, and everyone can chime in.
So I think that, harm reduction really means meeting the person where they're at. Whether that be that they're using and can't find a way to stop, or, they've relapsed and that they're trying to get back onto a road to recovery. It's just meeting them where they're at without judgment and trying to find the best way to get them to where they need to be. It's important to me. I mean, I've got lived experience in it too. I know I don't have that listed, but I do. I have a whole background in it. And I've seen people die. I've seen people go to prison, lose their whole families. And if there's any way to stop that from happening, like, I'm all for it.
I echo a lot of those things. For me, what really resonated about harm reduction was seeing the inherent value in a person, regardless of what they do, what they ingest in their body. And a big part of kind of what opened that up to me was going from primarily experience with like cardiopulmonary chronic conditions, so COPD, heart failure, those kinds of things, diabetes. And when I went into medically monitored detox, I thought it was going to be this whole new world. And it was in a lot of ways. But when it was framed to me as this is also a chronic condition, it really clicked for me, and it made a lot of sense because a lot of times, certainly there's a lot more stigma, I think, placed on mental illness and substance use disorders. But people with any kind of chronic illness still face a lot of ableism. And so it was really important to me to kind of listen to those voices. Yeah.
I think for me, for harm reduction, I mean, I come from it from a medical perspective, and I really strive to use evidence-based practices when we talk about harm reduction and when we think about things like that. So, when we talk about maybe a clean needle exchange, that is harm reduction, and that has good medical evidence behind it that it will reduce things in the population, such as hepatitis C and HIV. So, and those are a little bit of, as most of you probably know, a little bit of radical ideas from a traditional medicine standpoint. And so really, I think harm reduction also encompasses that stigma reduction. And I would agree with everything, as Kevin said, meeting people where they are, but really using some of that evidence to also help guide our practices.
Now, for me, I kind of agree with Dr. Osman and Kevin there. It's more about meeting people where they are. And I feel like harm reduction is so important to me because I am the face of harm reduction. My family is here because of harm reduction. My son's here because of harm reduction. I am living proof that harm reduction does work. It does help people, and it is worth the fight.
All right, awesome. Thank you so much for everyone sharing. Okay. So are there any additional benefits to harm reduction that that we haven't talked about when discussing why you all think it's important?
So one thing that I could add to that is that when you do meet somebody where they're at in a harm reduction kind of way, you're easing them into treatment. Treatment is really scary for people, especially if they're trying to come off of a substance or if they're considering making that change in their life. When you're wrapped into a substance, it's your whole life, it's everything. And so if you get to a point where you're thinking, maybe I should make a change, and all or nothing change is super overwhelming, and people don't even want to step through the door. But if they know that they can walk through a door, talk about their issues, and not be judged by it in any kind of way or forced in any sort of direction, they're more willing to have a discussion. And I think that that's just kind of like the opening to try and get somebody some help.
The other thing that I've noticed, just even in the literature, is that supporting harm reduction measures doesn't just help people who use drugs, it helps the entire community. At the end of the day, people who use drugs also matter, period. And they're worth the changes that happen when we put forward those measures. But in areas where safe syringe exchanges happen, or even consumption sites where it first started in New York, where there's actually sites where people can come and inject drugs in a safe place. They have naloxone there. It saved thousands of lives. And crime actually does not increase a lot. There tends to be a lot of backlash when those kinds of things are introduced or if they're mentioned in funding. But it doesn't increase crime in cities. It makes those communities safer. It makes those communities healthier, happier. And when access to needles or any kind of those pieces are restricted for people who use with drugs, they're also restricted for people who use, if you've ever tried to get needles for your grandma who has diabetes, sometimes some pharmacists will give you a real stink about why you're buying those needles. So that's kind of the other end that I kind of push, is that these things don't just help people who use drugs, they help the community.
All right, yeah, so there definitely was some additional benefits to harm reduction besides the ones that were first mentioned. And I know Marita started talking about harm reduction in terms of like the community, but that brings us to our next question of how can we educate our community on the benefits of harm reduction?
So I think this gets a little bit trickier when we're talking about how to introduce this to a community, because you have to know who your audience is, right? And so I think, I kind of would echo what Dr. Osman says, and the statistics are kind of like key in being able to show people that this can be successful in certain ways. There are other types of harm reduction that I think just have to be talked about because they're just not out there statistically yet. There's not enough studies on them to show that they're beneficial because they're new. And so I think also incorporating people, a lot like yourself, Micah, with lived experience, that can tell you, hey, this worked for me. My family is here because of harm reduction. That's the most powerful statement that you can put out there. If you say that to people in your community and that they're coming at you in a certain kind of way after that, then there's another problem. There's a bigger problem there. And so I think showing that, it's just cherishing life and it's just promoting life in general is a big key as well.
I think it can start small too. It can start. I know for me, it started internally with kind of confronting my own assumptions about people who use drugs and confronting kind of my own drug use. But it can start small at your dinner table. Honestly, it can start at Thanksgiving. Just talking about either what you do or talking about an interesting article that you read, or sharing those little pieces can make a big difference, because the fact of the matter is that everybody loves somebody who uses drugs. Truly. It's not a problem in another community. It's not a problem on the other side of the tracks. It affects everyone. And the more that you see that, I think I hope the easier it's going to be for people to understand that this is a pathway to recovery.
So it seems like some of you have already had conversations about harm reduction in regards to communities. So have you been successful while discussing harm reduction with others? And maybe if you could add on, is there any way that you've been able to like convince people or show people that harm reduction is important and something that we could all learn more about?
I can kind of start with this one. I have been working with our local pharmacists, especially at the smaller pharmacies, in the state of Illinois, you can buy 100 needles at a time from a pharmacy without a prescription, no matter who you are. And so working with the local pharmacies about that, because they were still, when I talked to them about that, they were like, well, you know, if they have a diagnosis of diabetes, if they have diagnosis of B12 deficiency. So sort of getting them to see the benefit of not restricting people on that. So that's how I have worked on that to some extent, as well as, I mean, my family hears it all the time, and my kids are teenagers, and so they have been, you know, we talk about these things quite often, but so that's how I'm kind of coming at it, from trying to get other medical professionals on board. And of course, being on panels like this, where we can kind of share with other community members who are willing to come. I think it is a little bit different though, when they're, you know, people aren't coming to these panels and they're not coming to the events that are hosted. And how do you get the word out that way? And I think it's just a little at a time, and just continuing to talk about it and trying to convince others. You know, I mean, it's in this area, you know, I could say, well, if you're going to be pro-life, then you've got to want to save everyone's lives, right? So there's a lot of that kind of stuff going on. So I've lived here 25 years. And so it's a little bit easier for me to say some of those things, because, you know, I'm not coming in from the outside and trying to convince other people that I'm legit. I mean, I still am trying to convince people, but I can get away with some of that stuff a little better.
One of my favorite ins, and it was one of my ins, and it doesn't work for everyone, but if you believe that abstinence only sex education doesn't prevent pregnancies and abortions, then you can apply that as well to abstinence only treatment for drugs. Abstinence only treatment for drugs does not prevent overdoses. And if that's certainly right now, that's kind of the flashy headline in the news is overdoses. And the evidence is there. An abstinence only approach it's the same as it is in that category. It doesn't work. It's because there's a million ways to recover, and they're both risky activities that ways.
Yeah, for me, it's like I've said before, it's kind of hard to tell somebody that is standing in front of you because of harm reduction that it doesn't work. For me, the most success is telling people that I went through methadone treatment. I was on it for 3 years. I've been off of it for 4. And you still get the people, even when I first went into the methadone clinic, I didn't get approving looks from my family like I was fixing anything. I didn't get that until I had completed the program and successfully made it through. You kind of run into roadblocks with people, and you got to know your crowd. And I know we've said that a few times here already. It's slow and steady wins the race. I feel like getting the pillars of the community, having an equal amount of people like me and people like Dr. Ostman, who are professionals that are out doing this, it makes us kind of the perfect team being together. She gives statistics. She's a trusted opinion from the community, where a lot of people, if I'm standing there alone, they're like, oh, she's just some ex-drug user, don't listen to her. So I feel like having both of those is equally important as all of the other things that people have said already.
Yeah, I completely agree with everything that's been said. You know, part of the reason that I went out at 28 years old and went through all the school to get an LCSW was to have a little bit of legitimacy when I'm talking to people, because they do kind of look at you like, oh, there's just a drug addict standing over there talking about harm reduction, or, you know, whatever it might be in their thoughts. So that's 100% true. I think that, you know, the most success that I've seen has been working with my clients directly and their families. And so, you know, I'll treat a client the way that I treat them, meet them right where they're at. I help them work through their issues with substances. We try to see if there's any kind of like underlying mental health issues that are going on. help get them to the right people to help treat that, get everything rolling in a positive direction, discuss any concerns with their families. And then when they are having success, they spread the word. This is what happened in my therapy. And then other people want a part of that, and so then they come to see me, or they come to see somebody else that's practicing the same way, because they're not facing the same kind of stigma or judgment or the other things that could be present, if it's being looked at in an abstinence kind of way.
All right, awesome. Yeah, it seems like when discussing harm reduction, it's really important to kind of take various different pursuits when having the conversation. Like I think when Marita was talking, like having those analogies and being able to, show people or relate to them about different other concepts that are kind of relatable to harm reduction. But then also how Dr. Kate was saying is like, sometimes actually like challenging people on their thoughts and beliefs, which sometimes we can be hypocrites and or contradict ourselves. So it's good to be able to have those critical conversations with other people. But I know Micah and Kevin talked a lot about treatment and recovery, which brings us kind of to our next question, which is, in your opinion, what is harm reduction's place in drug prevention, treatment, and recovery? I know we've kind of glossed over this briefly, but if anyone would want to answer to this question.
I have a lot of thoughts on this, so I'll give a few of them. I do think I've heard people say a few times with the medications for opioid use disorder as being a harm reduction. I actually think it's more of a treatment for a chronic illness. I think there's other pieces of treatment that can, that factor into harm reduction, because I agree, I don't think everyone's goal is abstinence. And whether we're talking about alcohol use disorder, tobacco use disorder, opioid use disorder, so harm reduction might just be moving that needle in a small way of using clean supplies, maybe reducing, but again, abstinence isn't certainly isn't everyone's goal. And harm reduction in drug prevention, I guess I would have to think a little bit more about that. I don't know that it's been presented to me in that way. Maybe other people have some thoughts on that, but there's definitely, lots of areas in treatment and recovery that we can employ that harm reduction, harm reduction.
So again, this is kind of like a loaded question. There's a lot of information that I could go to, but I think that, harm reduction's place in treatment and recovery needs to be the start. I think that whatever the client's goal is, whatever this person wants to do needs to be the start. And we're more of the guide, to try and get them to their goal. So in drug prevention, I feel like, the best place for harm reduction is just education and kind of putting it out there as a treatment method, because a lot of people won't accept it, especially in Central Illinois, just kind of in general. You say the word harm reduction and it's almost like a foreign concept unless you're in a bigger city like Bloomington or something. So I think just education on what harm reduction actually is where the place in prevention would be for me. As far as treatment and recovery, I think that harm reduction, like I said, it's just kind of easing people into it, because recovery is a long game. This is not like something that we're going to do in a day and bam, you're cured. This is a long haul. And so wherever we can start, wherever we're making progress at, that's okay with me. And I think that that's where the place is in treatment and recovery.
I think that's what's so great about it too, is using harm reduction as sort of a philosophy, not just actions and supplies, but as a philosophy allows that space for what recovery really is, which is, of course, that non-linear kind of back and forth, that fluid journey. Because when there's so many limitations placed on what your recovery is supposed to look like, when there's insurance limitations on how many times you can go to a detox center, when those limitations are put in place that don't have that that person-centered approach, it really does harm people at the end of the day. It prevents a lot of recovery. It kills people. It's very harmful when we're not able to meet people where they're at.
I also, I also really feel strongly that harm reduction isn't always like, a medical treatment. Sometimes, and I think Dr. Osman was kind of echoing this earlier, how she sees, Suboxone as a form of medical treatment, which I can agree with that, because it is in itself a medical treatment. But harm reduction can also be like the guy that comes in that drinks a case of beer every single day. And so how many are you willing to give up today? Are we going to go down to 22? We're going to go down to 20 cans of beer, and let's hold that. And let's see how long we can hold that. And when you're ready, we're going to go down to, 18 or 16 or whatever you're comfortable with. It's working people in the right direction. Kind of like we had talked about earlier, not everybody is ready to just quit and be abstinent. And sometimes a substitution or a reduction is a better path. It just really depends on the person and how committed they are to the journey.
All right, you all had some great things to say. So it seems like harm reduction or introducing harm reduction to prevention, treatment, and recovery ultimately gives more options for people that are wanting to start their recovery journey, or just people that are struggling with substance use in general. I know it's mentioned that harm reduction is kind of like a newer concept and it hasn't been too deeply researched, but are there any numbers or statistics that you guys know of off the top of your head about harm reduction? Anything to support harm reduction? Is there any data available that you would like to share? Success rates? Or I guess even Micah, you are proof that harm reduction does work. You are part of the success.
Anecdotal data is absolutely data. People's success stories, individual success stories absolutely do have an impact. And sometimes I think in the scientific community, we're trained to look at information from a very specific, limited point of view. But the fact of the matter is that those individual pieces add up, and it's really important not to devalue those stories, and making sure that policy, all those pieces are really driven by the people that are directly affected, by people who use drugs, by people who are in recovery. Those perspectives are extremely important.
I don't know like specific numbers, because I feel like it's really hard to test these things on a large scale. If you're looking for a lot of empirical research on, substituting one thing for another, that might be less. Like if we're talking about marijuana, for example, it's like kind of the hot button topic in the state right now because it's recently legalized. There's no long-term studies on marijuana and how it works in treating like opioid addiction or treating alcoholism or anything like that. But there are success stories, and there's a lot of them around the country. And it's kind of like the Wild West, because we're talking about marijuana in a raw form. It's just now legalized. They say come to the dispensary and get it. You get a medical card, we're going to knock the taxes off of it. NIDA has a hold of it. NIDA's doing long-term studies. Stuff will come out. Eventually, they're going to synthesize the ingredients in marijuana that can be most helpful to treat things. But it's kind of like listening to people right where they're at, hearing their stories, and how is it helping them stay away from what they want to stay away from.
There is also solid evidence that, for instance, using safe smoking kits, so anything that can be injected can also be smoked. And there's risks and there's benefits certainly between all of them. But generally speaking, if you're smoking something, you're less likely to get an infection, certainly from poking, from breaking the skin, and you're also much less likely to overdose. So there is a lot of good information about promoting safe smoking kits, so that's an option, so that people might have the option to smoke instead of inject, which of course makes a lot of hubble when it comes to legislation and communities and town hall meetings. But it's those kinds of things that are important to talk about and to bring up. If you are thinking about like dinner table conversations and you're looking for maybe books to read, The New Jim Crow is a really good book that talks a lot about how drug policy over the last couple of years has affected Black, Indigenous, and people of color populations disproportionately over the last 100 years. Hungry Ghosts by Gabor Mate is also a really good book that has a solid chunk, I think a whole chapter that's about focused on harm reduction. So those are a couple of good books that have some solid research on them.
Awesome.
Thanks. Also, there's lots of research and there's lots of positive outcomes out there about syringe exchange programs and reducing the infection rate in a community. And there's also good studies out there on Narcan, community-wide Narcan distribution and reduction of overdose death rates. So it's not that there's not data out there. There's definitely data out there. And I agree, some of the things that we're talking about, we don't have data. We do have data though on something like seatbelts, right? So from a harm reduction standpoint, if we never ever got into a car, we would never ever be involved in a motor vehicle accident. Now, let's not talk about if we're riding our bike and somebody hit us or walking along the street. But so that would be, abstinence from driving. You would never be involved in a head-on collision or even riding in a car. So we said, okay, let's do seatbelts, and we have studies that show seatbelts are effective. So again, that's a way that you can talk to community members about that, about what harm reduction means and what we're looking at. We also have studies that show that birth control pills and condoms, access to condoms, do not increase teens having sex. So that was also always a big concern, right? So it's a little bit hard to somebody mentioned before about pregnancy rates and abortions and things like that, but we do know that it does not increase the rate of teens having sex by them having access to these things. So those are things that we can look at, and there is data coming out about around substance use disorder and some of these other issues.
Great. Yeah, just to kind of sum up, especially with what Dr. Kate was saying, just a lot of the statistics are around, creating safety through harm reduction. And I also want to thank Marita for sharing those books. I hope people are able to check those out. I think there is a documentary or something that's kind of around the new Jim Crow on Netflix or something, if you're more of a visual person. So we're going to dive into kind of more the deep or the hard-hitting questions. First one is, some people view harm reduction as enabling or encouraging the person using. How would you explain the harm reduction perspective of that narrative? Or I know, not to pick on you, Kevin, but I know that you said that you worked with clients and their family. How I don't know if you've ever had to explain harm reduction to them and how that may affect them.
So people, and it's not everybody, but there are people that have in their mind that abstinence is the absolute only way to recovery. They see drug use as a moral failing and as something that you can just switch on and switch off and you make your choices. It's not that way. It's a chronic disease, as we all know. It affects a lot of different things in your brain. It affects the way that you experience pleasure. It affects so many different things in your life that there's no possible way that you can justify it as a moral failing. And so just kind of explaining the way that different drugs act on dopamine is a big help for me, and just kind of like letting them know that if they're easing into some other kind of path, that they're still getting some kind of artificial dopamine that's letting them feel their feelings. It's letting them feel pleasure, to feel pain. And it's not that numb, just kind of what the heck is next feeling. because a lot of people get trapped in that, especially if they just go cold turkey. They go through this entire painful withdrawal from whatever substance it might be. And then it's just like that flat, like, why did I even do that? What's next? You know, because you don't even know what your life is like at that point. You have to put everything together. It's like finding an entire new identity when you quit using drugs. And so I just kind of talk to them like that. And sometimes I draw a little picture, like make little dots for the dopamine. And that seems to go over really well visually. But it's a terrible drawing, so I'm not going to show it.
I've thought a lot about this because it's a fairly common response to see this as a way that is showing them that drug use is okay. I've decided to look up more about kind of what enabling is, kind of what the definition is, and where it's how people look at it. And a common theme that I kept on seeing was essentially doing something for someone that they should be doing for themselves. And to me, what an important distinction is between that and the harm reductionist perspective is that so much systemically is set up that the people who use drugs don't have access to those things. It's harder for them to get clean needles. It's harder for them to do these things because of the ways that are set up. It's hard to get into treatment. It's very hard to get into treatment. There's a million different barriers that come up, even from within the system. There's many people within the treatment systems that can make it hard for you to access treatment. I could also go into the idea of what someone should do. To me, part of what harm reduction says is that substance use is something that humans have done as long as they've been humans. Humans have been taking things into their bodies to change their experience ever since there's been humans. And I don't think that it's something that can be prevented necessarily. I think that there's controlled use and maybe chaotic use of different substances. But to tell someone what they can or should not be doing, it gets into kind of tricky territory. Now, you might have an argument when it has consequences, when there's harm that's produced, not just for the person, but for someone else. Then that brings in the questions of accountability. You do have to have accountability for the actions that you have. That's an important part of recovery, absolutely. But the idea of itself of enabling, I don't think necessarily matches the reality of what's true for a lot of people who use drugs.
Yeah, for me, I guess it depends on what kind of harm reduction that you're talking about. Now, if you're talking about clean needle exchange, Narcan, my point is always everybody deserves to be healthy. Everybody deserves to be alive. And we cannot save people who are permanently damaged from HIV. I mean, there's more treatments now than ever before, but these are things that people permanently have. Now, for me, when I was actively using, clean needle exchanges were not a thing. That was 7 years ago. That was not heard of. I know personally, I shared needles. I used not dirty toilet water, but water out of a toilet to use with. I mean, that's putting that out there and explaining to people that this person standing in front of you used to do those things and make those decisions. And I don't deserve, even then, let alone now, to be permanently affected by my decisions when my mind was not in the state to be making correct choices. I feel like that has a little bit more weight behind it. Now, if you're going more the MAT or MAR, whichever you guys are used to calling it, I do admit that, yeah, it was a crutch for me. But when somebody breaks their leg, you give them a cast and you give them crutches. Crutches are fine. We use them until we're healed and we're stable enough to function on our own. And that is exactly what it is to me. So.
And some people, if we look at it from like an anti-ableist perspective, there's some people that use crutches all their lives. If that's what you're using to walk, let's celebrate it. You know, it's yes, a crutch. Oh, it's a crutch is a good, if a crutch helps you walk, then a crutch is a good thing, you know?
Alrighty, tons of different amazing perspectives and conversations going around this question. But another one, another hard-hitting question, or I guess if we can share our experience on this, is what are some hurdles that you faced while discussing harm reduction? Was there any backlash from others, or maybe even in your community?
I think generally when I'm talking to someone about drug use, I think a lot of people are pulling from personal experiences that they have. I think some of it is people don't actually think they know people who use drugs and make a lot of assumptions, and those assumptions are fueled by entertainment, and they're fueled by many things. But I do think sometimes that people have an experience with a loved one who uses drugs, and is coming from a place of clearly this is something bad for this person that I love, and it resulted in bad things for me. So sometimes when they're coming from that emotional perspective, and that's a valid experience of theirs, it can be hard to hear that someone would hand them a needle to keep using, I think. And so to me, part of the response to that is being there for that emotional response, because it's absolutely valid. Drug use, to me, what's great about harm reduction is, while it is offering that healthy, you matter as a person who uses drugs, you deserve to be as healthy as possible. It also is not denying the harm and the destruction that chaotic drug use can have. It fully acknowledges that it's harmful, that it can kill people. So holding those both at the same time, I think, that's an important part of harm reduction. That holding two truths at the same time can be hard for people. So.
Yeah, I think there's a couple of different perspectives with this. So, some of the hurdles that you face are just, hey, they're not clean. They're not completely clean, so they're still using. They still have a problem. They're still in their addict mind. Those are some common responses that I would get when discussing harm reduction with people's families. And then, from the community, like, there's a perceived backlash, and it's not from everybody, and it's getting better. But it's like in my community in particular, and I've lived in Livingston County my entire life, it is kind of like an unspoken thing that there is these huge drug issues in every little town that sits on 24, or that Pontiac and Streeter have major drug issues, or that there's all these drugs flowing from Chicago straight into Dwight. Like, these things aren't talked about all the time. Some people are, and there are good community events that happen around Livingston County. But for the most part, like, if you go talk to the old farmers that are out on the road that have the power and the money, like, they're not talking about drug problems in Livingston County, And so it's kind of almost a double-edged sword, where it's like, if you do talk about harm reduction with somebody that does have a family member who is struggling, it's, oh my gosh, well, they're not completely clean. We can't put this out to the rest of the world. We don't even want them to know that they were using it in the first place. And on the other side of things, it's kind of like, what drug problem? We don't have a drug problem. There's just people overdosing every day dying. So.
All right, I'm going to pick on Dr. Kate. Do you feel like there is some hurdles within like the medical community, or maybe with other doctors? I know you mentioned talking or working with local pharmacies about like the needle exchange or needle purchases, but do you feel like there's other hurdles that you experience as a medical professional?
Well, and I was gonna address this anyway, because someone brought it up in the chat. I actually give an hour-long talk on this about where we are and why primary care persons in particular are not good at dealing with this. So until very recently, you were I graduated from med school in 2001. And through that time, it's been perceived that it was against the law. So you could lose your medical license, and you could be thrown in jail if you treated folks with opioid use disorder with opioids. So outside of methadone clinics, that was, those were the only thing. And so it was very much criminalized. And because of that, then most of us were not trained in any of, in specifically opioid use disorder, but, we had a little bit of alcohol use disorder, stimulants, no, not really. And it goes back at least 100 years as to why the medical community perceives this as a criminal problem, a criminal justice problem, and not a medical problem. That is changing. Now, starting this summer, internal medicine residents are required to have certain addiction medicine rotations. Family medicine is getting there as well. And there's some other groups getting on board with that. But it's more of a lack of knowledge than, and because of that lack of knowledge, then lots of stigma and lots of bias. So when you go to a provider and say, I would like you to prescribe Narcan for me, by the way, you don't need to do that in the state of Illinois. The state of Illinois, there's a standing order. So you can go to most pharmacies and just get it and your insurance will pay for it. That's besides the point. But it's because of how the system has been built and where we are up to this point that those, that fear, that ignorance, that bias still exist. So that was sort of a really long answer to your question, but I kind of, that's where primary care providers are coming from, and ER doctors and all those folks. And so trying to, continue to change this and to work with them and to see how we can maybe make this different. Physicians are accepting of it. We take care of really hard things. We take care of, people have mentioned before, diabetics. I took care of OB patients. That's really high risk. So these patients are not really high risk. It's actually really fulfilling and really a great thing to do. And the medications are not really high risk. But it's because of what's happened over the last 120 years that's made it really tough to get our minds around that, if that makes sense.
For sure. I think a lot of it kind of stems from, I guess you're talking about the medical community, but I guess in general, it seems like there's a lot of education that needs to be brought out to everyone. But I guess the biggest struggle is getting the education to everyone in all those different types of corners of our world. And I guess speaking of other little niches or groups, I'm not sure if anyone has personal experience with abstinence-based groups, or maybe you're familiar with them from working, but what's the relationship between harm reduction and abstinence groups? Are there opportunities for them to come together? And for people maybe that aren't familiar with abstinence-based groups, for myself, I think of like Alcoholics Anonymous, AA, or NA, Narcotics Anonymous.
In my experience, I feel like, the relationship is on the rocks a little bit with AA and NA groups versus harm reduction techniques and different kind of maintenance programs that are out there. I can tell you that there is a lot of hesitancy with people who are thinking about joining up with an AA or an NA group, because if they are on a maintenance medication or they are reducing whatever they're using slowly, they feel like they're going to get judged when they walk in the door. Whether that's true or not, it's just group dependent. So it's like, one group might be one way and another group in a different town might be a completely different way. And so I always encourage people to experience different meetings when they're first starting out. Like, go hit this one, we can give them a meeting list. And these towns are all real close together here in central Illinois. And so there's plenty of meetings that they can get to, so long as they have the transportation to do it, and the gas money nowadays. I think that there are opportunities for them to come together, but I think that the people that have been in AA and the NA groups that are kind of established, the people that have been there for 10 years doing it every day, 15 years every day, would need to be educated on harm reduction and what exactly the goal is of harm reduction. Because again, it's like, when you get into an AA or an NA, if you're using anything, you're relapsing, and so there is kind of like a negative correlation there, but it's not every single group. It's very group dependent.
I think a lot of it too has just the idea that what works for one person doesn't work for another person. Just that simple concept, I think, is just the place to start. And even within those groups, that is true. You know, even within someone who's doing a 12-step program, not every little quote, not every little chapter is going to resonate with everyone. It makes me think of like when Demi Lovato said that she was California sober, which is essentially monitoring her drinking, being thoughtful, being a mindful drinker. And I think it was Elton John who came out really staunchly and was like, that's not that's not recovery. You're not. It was just a very immediate response, like that's not going to work. It sounds like it wouldn't work for you, Elton. It's what she's got going on. So there is kind of an opportunity, I think, for just communities of drug users to be more accepting of each other's journeys, that what works for one person isn't going to work for someone else.
For sure, yeah, I think there should, oh, sorry, go ahead, Micah.
Oh, you're fine. I was just going to add that in my experience, just personally, they don't really go together. There is some groups, I'm a little biased because I run a SMART meeting now, but I really like SMART. I feel like they're kind of the first group that really leans more towards let's meet you where you are. Now, I've been told many times by different groups, I will not name names, that I am not sober and I wasn't sober when I was on methadone, and that I do not have 7 years of sobriety. I have 4 years of sobriety. Like Kevin said, I think the ones that have been there for 15, 20 years, they really just need the opportunity to be educated on the benefits of MAT or MAR, whichever you guys prefer. Once we can educate and bring a little bit more of that acceptance, I think we do have a road into those, but I think we're a little ways away if we're being completely honest.
Yeah, once again, I feel like it brings us back to the education point, and with the abstinence-based groups, it seems like they have a set of rules and things that they live by, but if they want to have the opportunity to come together with people that believe in harm reduction, I think open-mindedness is key. I think we could all use a little bit of more open-mindedness nowadays. And then just to touch on this briefly, I know we already kind of talked about this, but this was a question kind of going on with not being sober enough. So we'll skip that later. But the next question is, as a prescriber, what are some of the biggest misconceptions about medication-assisted recovery? I guess that's kind of pointed towards Dr. Osman, but Marita or Kevin, if you guys have experience about just working in the field as well, I would, and I'm sure everyone else would love to hear your perspective.
I mean, I think from a physician perspective, the biggest misconception is that this drug is, well, specifically buprenorphine. We know that methadone's been around for a while, but if you want to do office-based treatment and you want to do buprenorphine or naltrexone, you know that these must be dangerous or scary. And of course, naltrexone, anyone can prescribe. The buprenorphine, you have to have this extra layer of training, so it must make it worrisome. So that really is the biggest misconception. The other thing that is, it feels like a misconception, but it's not, is that the patients, well, if you prescribe it to them, they're just going to sell it. That's really true, right? Because there's not enough of us prescribers prescribing it. And there's a lot of people out there that would like treatment. And so I would love to say that's a complete misconception, but it's something that we're working on. And it's, something that we talk to patients about.
And it still supports someone's recovery. It still saves lives.
So I would just chime in that, a lot of people see MAT as a Band-Aid, something that could easily be ripped off and everything could go back to the way it was, or that, in the case of Suboxone or methadone, they are automatically going to abuse it, That's the biggest misconception that I think I get consistently. And you just have to explain to them that it's all about the will. You know, it's not all about the will, but you've got to want to recover, and you've got to be in a program to recover. And so it's like, you know, there are people out there that are just kind of like, I don't really want to do this, and they're not ready for it. And I think that sometimes when a person like that gets into a methadone clinic or into a Suboxone clinic, that things can get carried away really quickly. And it's probably for a brief amount of time before, you know, they're caught on to and they're kind of worked with to get into a space where they can continue with their program or try something different that's safer. But if you get a person who is truly trying to recover and they are in a program that is kind of, you know, monitoring them and making sure that they're not getting out of hand with it, and at the same time that any underlying mental health conditions are being treated as they, you know, emerge. Cold turkey is, those are my thoughts on it.
All right. Any last thoughts about the misconception of MAR or MAT? Alrighty. So we're gonna skip the being sober or not being sober enough question. We kind of briefly talked about that, but we're going to start tying some things up now. One of the last questions is, what is one thing you would like for people to take away from this panel today?
I think the biggest thing that I would like people to take away from this panel is that no matter how you choose to recover, that as long as you're recovering, if you want to go the MAR way, if you want to go complete and total abstinence, if you can get together with friends and sing Kumbaya around a campfire, no matter what, if you're progressing towards recovery, you're going in the right direction.
Wonderful ladies, do you have any last words of advice or wisdom that you would like to give to any of the panel watchers?
I think I mentioned it before, that just the simple concept that even people who have no intentions for treatment or no right now intentions of wanting to recover, whatever they think that means, those people matter, and their health matters as well. And the idea that all pins down to the idea that drug use isn't necessarily a moral failing. Certainly it can result in actions that we could assign morality to, but drug use in and of itself, to me, is morally neutral. And keeping that in mind can help you to have more of a changed perspective of people who use drugs.
For me, I just kind of want to tell everybody that this is a tough fight, but it is one worth fighting for. And I just want to thank every single person on this panel, because people like me wouldn't exist if you guys weren't out here fighting the battle too. So just everybody speak up, share your truth, and hopefully one day we will make a bigger difference than we ever thought possible.
Alrighty, and then in your utopia, what are some aspects of harm reduction you wish you could add to your community? I know we briefly talked about needle exchange. Is there anything else that maybe you guys would put into your community in some sort of dream world?
complete acceptance and people being a little bit more willing to be open to the idea. I think we have an awesome army ready to fight, but I think we just hit so many roadblocks that it really makes it tough and people get burnt out real easy.
I want to see it all. I mean, I think that if there are ways for people to recover that aren't in the community, we need them in the community. People have choices. People are different. You know, this isn't like such a huge state that you can't drive somewhere else and get the help, but why not bring the help to the people that need it here? So I think that, you know, my answer would be bring it all as much as you possibly can.
Yeah, I would love the beautiful idea of no wrong door is kind of a mental health substance use concept where if someone wants to come in for treatment, doesn't matter, they came to the right place, no matter what they're using, no matter where they are, no matter what they're looking for, no matter what path of recovery. And boy, oh boy, operationalizing that is really, really, really hard. So I would love for that to actually exist.
Alrighty, so I guess that brings us to all the questions that I have today for the panelists, but I've seen the chat box glowing, so I think some people have been asking questions or leaving some comments, so I'm going to scroll through those real fast to see. So I know that Dr. Osman answered the question about naloxone. I don't know if I pronounced that correctly.
Naltrexone, I think, is what I saw in there.
So I guess this is for Micah. Mary asks, what is a SMART group?
Okay, so Smart Recovery is just, it's another group like NAAA, the ones that you guys are familiar with. They just have their own points, their own system. It's very much about, it kind of puts the power back into your choices rather than being powerless, which I really like. I do believe we are powerless at some point, but I liked having that control back in the way that SMART views that. It's just a little bit different. They really get into changing your cognitive thinking. And that's in my experience, that's one of the biggest problems that we have, is that our brains just don't work like everybody else's does, or the not sick people do, right? So SMART really focuses and gives you the tools to change those cognitive thoughts into positive thoughts and how we're actually supposed to process our thinking. Does that answer your question? I hope so.
And then I believe, correct me if I'm wrong, SMART is a free support group. And then I believe you can go to smartrecovery.com and locate meetings near you if that's something that you'd be interested in, or anyone else.
Yeah, it's actually smartrecovery.org. Yeah, but they've got online meetings. They've got a whole online forum. You can attend Zoom meetings if you're not, which I'm finding, especially with the younger generation, they're not too keen on peopling and going to meetings. So a lot of people really like to take advantage of the online forum. I think it's all great. If there's any other questions, you can find most of it on there, but feel free to reach out to me if you do.
And one of the things about SMART too is that it's a non-faith-based recovery program. So there's a lot of folks that just aren't ready to walk into a faith-based type program. And maybe they will be down the road, maybe they never will be, but that's sort of one of the tenets of SMART as well.
And then Micah, Barb asked is your meeting hybrid? I don't know if maybe you want to plug your meeting in.
It is not. I'm actually not sure how we go about making them the hybrid meetings right now. I don't know if that's possible. I don't know if SMART even does a hybrid meeting because they have the option for completely online. I will look into it and let you know though, Barb.
All right, so I think that was mainly the questions. Patricia had some comments about some of the discussions. Patricia says, I believe that distributing Narcan, fentanyl, test strips, and clean supplies to people who are using is a branch for them to hold on to. And when they are ready to recover, they can ask for those resources. If anyone wants to comment on that, I think most of us would probably agree with Patricia. Being able to have some sort of smaller accesses to help will lead to recovery. Patricia also says it's very painful when you reach out to someone for help in recovery and you get the door shut in your face or you don't get any response. Okay. So I think that's most of the comments and questions. Does anyone else want to touch on anything else before the panel or discussion ends? Okay. Jeff says if we think about traditional healthcare as a continuum of care, MAT fits right in with that concept. Yeah. All right. Well, if no one else has any questions or comments, I would like to thank you on the behalf of McLean County ROSC and also the Livingston and Ford County ROSCs. I think the panel went really well. I'm really grateful for the panelists that showed up to discuss everything today, but also so grateful for everyone that came to listen to everyone chat and, start this conversation about harm reduction. And then, all right. So have a great night, y'all. Thanks for stopping by and thanks for participating.